of postoperative endophthalmitis, redetachment, silicone oil, positioning, and for all cataract surgeons also, we go through our consent form. So these are three things I will tell before I start my presentation. And first, let me go through the history, the machine, the clinical features, FFA over OCT, and diagnosis and classification, and deciding on the treatment. History. Why am I talking about history? The first angiogram was done in 1961, and it has been 50 years since the angiogram, and most of us here, I'm sure, have an FFA machine still in our practice and are doing FFA. So this shows there is a definitive indicative role for fundus fluorescent angiograph in treatment of diabetic macular edema. And I also have a small box here which shows my score to make it easier for the judges. As far as the cost, there is no debate in this, and for the maintenance, I know because the fundus fluorescent is based on photographs and filters, it's easier to maintain. And advancements, yes, OCT might talk about all the spectral imaging, high definition imaging, choroidal imaging. Yes, even fundus fluorescent also has got its advancements, and you can see the images in which you can even see the venules and even each and every, and see how good you can see the foveal avascular zone. And this one picture is enough to tell everybody here that what diabetic retinopathy and diabetic macular edema is all about. It is not only about the center. Yes, the center had edema, you are treated with laser, but you are wondering why nothing is improving. It is because of the CNP areas in the periphery, you have NTEs, and these are the contributing factors for the central diabetic edema. So you keep only looking at the center. What about the remaining part of the retina? Who's going to see that, and what are you going to diagnose, and how are you going to treat the patient? So I'm not going to go into this. And there are just a couple of studies which compared OCT and FFA for macular edema, and they also found in this study that 4% of the patients actually OCT did not pick up the macular edema or any morphological changes. As far as OCT classification, Ramana Kumar has very clearly explained it is focal edema, spongy edema, cystoid cavities, and serous detachment. But now let us come to the treatment aspect. So what treatment is Ramana Kumar going to do here? Yes, he is going to give IVTA, he is going to give intravitreals, and intravitreals. So where is the role of laser in this? Yes, you might have steroids, you might have anti-VEGF, Lucentis, Osutex. But then, when you classify it according to fundus fluorescent angiography, you have the focal leaks, you have the diffuse leaks, and then when you come up talk about the treatment options, you have the focal laser, you have the grid laser, you can also combine the focal laser with the intravitreal injections. So these are your various treatment options when you treat the patient based on fundus fluorescent angiography. And pathogenesis, yes, it is a microangiopathy and it's something connected to the vascular system. So no better treatment than the fundus fluorescent angiogram to show you all the phases and what is the disease all about. If you see this clinical scenario, I know most of us would rate this as moderate, or some would say severe, I know, and some of the retina specialists would say like a featureless retina, yes. And the OCT might show some macular edema. And what is he going to do? Again, going to inject again. But then only when you do FFA, then he's also supported that you find this case of macular ischemia, you see the dropouts, and vision is not going to improve in this. So how many times are you going to inject this patient just looking at the macular edema, and after how many months are you going to decide, let us do an FFA to find actually what is the cause for the loss of vision? And according to what he said, all the studies of BRVO and this thing also said that definitely laser has a better role and long-term effects than intravitreal injections. And always remember, intravitreal injections, the rate of endophthalmitis is low, yes, agreed, but it is not zero. And this is this CTDRS study by the DRCR net in which everything has said that laser has better effects. And this was a meet that happened last week in Mumbai, in which I think Ramana Kumar was also present, and please listen to this carefully. Another volume? Volume.
God is there, Nivean. Have faith. You know? God is there. See,
this is a meet on DME in which Susan Bessler was talking. You can see the famous person sitting on the dais, and Ramana Kumar was sitting next to me. And all she said was how important the role of initial angiogram is in classifying and treatment of diabetic macular edema.
Help me answer, okay, now why is the edema persisting, or why has the edema gone away and yet the vision did not improve? So I do prefer to have an initial angiogram before I initiate therapy. And then for the most part, I don't keep it.
So I would conclude by saying, yes, FFA alone is like such a figure of a team, which is greatness, glorified, time-tested and godlike. Yes, some new people have come in and that's the OCT is more flamboyant, more fresh and more fantastic. But I would, as a retina specialist, like to conclude by saying, in a retina practice, only when you have both the FFA and the OCT, do you do 100% justice to the patient as far as treatment is concerned. Thank you.